right. Dr. Sussman, we are live.
Yeah.
You ready to go?
Thanks for doing this. Yeah.
Oh, my pleasure. My pleasure. All right. So I have a ton of stuff I want to go over, but I think in the beginning, the most important thing is to define what regenerative medicine is for folks who might not know what it is, as best you can.
Yeah. So it's kind of a buzzword you see a lot, but in orthopedics, it's kind of fallen out of favor to some degree. And we're transitioning more to orthobiologics, which, kind of orthopedics and biologics using your own cells to try to affect a change. And so for certain tissues, tendons and ligaments, there are studies that show that you can regenerate those structures. But for cartilage injuries, joint injuries, you can regenerate cartilage cells in a petri dish. We don't see really regeneration in the body. So it's not really an ideal term for what we're doing.
Oh, okay. Interesting. I mean, so from what I've learned about it, which is certainly more than you have at this point, I'm sure, right? It's an alternative to surgery for a lot of folks that they're not really aware of, and largely uncovered right now by insurance companies. And we can get into that more later, but I think just to begin with, there's a couple different sections. Is platelet-rich plasma, which has been around, from my understanding, since the 70s, even on some kind of a basis, but really in the US taken on in the early 2000s, and is now something that's readily available and still not really well covered for the most part.
Correct. Yeah, so initially it was developed to enrich platelets for blood transfusions. In the 80s, people started using it to speed up bone healing in surgical applications. And it really started to take off in orthopedics in the early 2000s, where some studies started to come out showing that it could impact tendon healings and then arthritis as well. You do see some coverage with work comp injuries, but for the most part, most commercial insurances and even public plans aren't covering it at this point. There's 20 years of data. There's if you search PRP in government databases of research studies, there's I think 17 or 18,000 articles out there. So there's a fair amount of data across the board. But for orthopedics specifically, there's more data for PRP and randomized control studies for knee arthritis than there is for cortisone injections.
Which is wild too. So it's not like this hasn't been studied. It's not like there's only been one or two studies. There's been hundreds of studies of this, and it still is not something that's common knowledge for folks. And I mean, so explain to me on the PRP thing, is it literally, it's using the patient's own platelets from their own blood. So what is it? You extract it, run it through a centrifuge or something like that? And how does that actually work?
The process is, we're concentrating platelets, which are one of the three main blood lines. So you have red blood cells that carry oxygen, and white blood cells that fight infection, and platelets that are responsible for healing. And so we're concentrating that out of your own blood. So you come into the office, we'll draw your blood. It takes us about a half an hour to an hour to process it through different systems. They're all FDA approved systems that have been looked at for safety. And then we numb up the area that we're treating and inject that back in to either stimulate a healing response with a tendon or a ligament, or to turn off inflammation in an arthritic joint for a period of time.
Okay. Now, when I was growing up, stem cells became like a big buzzword, like in the 90s. And then there were a bunch of organizations that were saying that they could do certain things with stem cells. We had the cord blood cells and all that type of stuff for folks having children. You also work with stem cells here, correct? And also something that I struggle to understand, exomes. So the best way I've tried to interpret that is exomes are almost like taking messages from stem cells and sending them into is there any way to put it in a way with someone who has not gone through medical school to understand what those are? And because exomes especially are kind of like, they're the frontier right now.
There's a lot of interest in those. So exosomes, they're little cell signaling hormones, essentially. So, when you inject PRP, you can have exosomes within the platelets that get released and stimulate a response from surrounding cells. And so at this point, they're not legal in the US. So the FDA has certain regulations in terms of what we're allowed to do and what we're not allowed to do based on what studies are out there, what safety studies have been done. And so exosomes aren't allowed. You see a lot of these cord blood or amniotic or birth tissue products. Those are also not allowed in the United States, outside some very narrow applications or as part of a research project. And so if you're not a research subject and you're trying to come into an orthopedic practice, you really shouldn't be getting amniotic products because those really haven't been studied to the degree that the FDA sees those as safe in the United States. And so, going back to stem cells, stem cells are a type of reparatory cell that lives in our body, and they're really characterized by where they come from. And so you can have stem cells that come from fat cells or adipose-derived stem cells or bone marrow-derived stem cells, or you can have amniotic-derived stem cells. The amniotic products that have been studied to take a piece of a placenta that has these stem cells in it and deliver it to a patient, you have to freeze or dry those cells, process them in a way that they're safe, and that process kills those stem cells. And so when you actually look at those products, you don't see live stem cells, even though that's how they're often marketed. So the stem cells that are allowed in the United States are derived from fat or bone marrow, and they're not pure stem cell products. To take your bone marrow and isolate a stem cell requires weeks of lab work that we're not allowed to do in the United States. So there are certain guidelines. So we deliver the bone marrow or adipose products that have a lot of stem cells, or a percentage of those that have stem cells, but there are a lot of other reparatory cells that are responsible for the healing process.
Okay. You keep on intentionally putting the word United States in there. Does that mean, is it much more accepted in Europe and in other areas?
Europe is well regulated too. There are certain areas in Central America and some islands where there aren't regulations, and so you can go to those countries and have a lot of stuff done that's not really well supervised, I suppose.
Okay, right. Which, I mean, there's a plus and minus to that stuff. So you can get certain services that you might not be able to get up here. However, a lack of regulation means things can go wrong. And so the stem cell work, is that covered by payers here?
It's not.
It's not.
Not for the orthopedic applications we use it for.
Okay. Now, there's other services that you provide here. You provide Tenex services. You provide shockwave services. I don't want to overwhelm everybody back home, but could you briefly let us know? Because I kind of, and again, I'm probably very sophomoric here, but I look at it almost like a 1-2 punch, where one of them is kind of like getting rid of scar tissue, and the other one kind of awakens everything to work again. Yeah. Do you use them often in tandem, or can you explain briefly like what they do?
Yeah, so our practice, so by training, I'm a physiatrist or physical medicine rehab doctor, and then have additional training in sports medicine and diagnostic ultrasound. So, patients that come into our office are often looking for an alternative to surgery. And in some cases, there are pretty good alternatives or minimally invasive procedures that can mimic or have similar outcomes to surgery. And we'll walk patients through those options. And so a lot of times you'll come in, we'll review your MRI or your X-ray. A lot of times we'll do a diagnostic ultrasound, which can provide additional information. And then once we have a pretty good sense of what's causing the pain and what the underlying issue is, then we can discuss treatment options. And that can range from anything as a simple cortisone injection or viscosupplementation, amniotic injections. These are often covered by payers. Sometimes it's taking a step back and dialing in a better rehab program or strengthening program, talk about nutrition. There are newer modalities, blood flow restriction and dry needling and trigger point injections and other ways of addressing pain that are also covered by insurance. And then there are newer modalities. Shockwave's been used in Europe for a long time. That's become more popular in the United States. It's a non-needle based, less invasive way of addressing chronic tendon pain or muscular pain. There are some bony applications for shockwave. And then we get into more of the needle-based treatments. And so Tenex is a device that we use to do these minimally invasive tenotomies that are under ultrasound guidance. There's a carpal tunnel release device that we use that is also done under ultrasound guidance. And in general, we're causing less trauma because the incisions are smaller, and we're using the ultrasound as our eyes instead of doing a bigger open procedure,
right?
Where you have to cut.
It's almost impossible to screw up. I shouldn't say it that way, but basically, like ultrasound accuracy just changes the entire game.
It does. Instead of having to cut through tissue to get to the problem area, and now you have to heal from the area that's injured, but also the surrounding trauma from the surgery, we're able to kind of bypass the healthy tissue to get to the deeper structures.
A simplistic way of looking at your practice is basically a lot of what you're doing is trying to have the body heal itself, which is, I think, where the regenerative former term, I guess now. Yeah. I'm a little dated then. But basically the idea is if there's a way to get your body to work for you, because when people look at surgery, and I've had many surgeries, I had surgeries when I was like 3, 4, and 5 years old that I have still PTSD to today, because I was a child when I had it. And, I think that, and my youngest daughter had it when she was 5 years old, and it was amazingly terrible experience. It was one of the more difficult experiences, and she certainly has never forgotten it. And I'm sure she's going to carry some stuff with her. So when I go into the OR waiting room, you just see people shaking. They're there with their loved ones. They're terrified. They know they're going to go through months of recovery, and they're worried about if they're going to wake up from anesthesia. There's so many things to be concerned about. And of course, certain things are more serious than others or life-threatening. But I think technically there's always a scare when it's anesthesia. So the work that you do can potentially be an option depending on the situation. Like I imagine if there's no tendon on the bone, typically you have to go through actual surgery, right? But as long as it's a partial tear with ligaments and the such, there may be options. Is that about right?
Yeah, and I think looking at everything unique, as a unique case, that individual patient coming up with a decision that, trying the least invasive, least expensive, some of these things aren't covered by insurance, so if we can do something that's covered by insurance, typically we'll lean in that direction. But least invasive, least expensive, offer the fastest recovery. And in some cases, these aren't options. We saw a patient, the last patient of our morning today, that was a full rupture. She'll do better with a surgery, and the faster she gets the surgery, the better she'll do. Yeah. And being able to coordinate with our surgical colleagues, in those cases. But, I think a lot of times, we bypass, these options. And I think there's a number in the United States where 30% of people end up with a knee replacement haven't tried anything else other than the surgery. And again, for some patients, that's the right decision. But a lot of times we can delay or defer surgery for a period of time, even in those cases, so that it fits into your life, your broader life.
Right. Now, I wonder, practically speaking, whereas if someone's a better candidate for surgery, you're going to let them know that. Does that often happen in reverse? Other patients who go in for a total knee replacement that are told about services like yours that might be a better fit if it was like a partial tear?
In some cases, right, but sometimes you have to be your own advocate,
right.
and do your own research. I think there's a study that shows that 98% of patients who have knee arthritis are offered a cortisone injection, and the number of patients who are offered a PRP injection is like 3%. And again, there's a study that came out earlier this year that we alluded to that, there's more studies, randomized control studies, so higher level scientific studies looking at knee arthritis and PRP, showing that PRP lasts longer and achieves significant clinical benefit in the medium and long term compared to cortisone injections. Mm-hmm. But I think the coverage issue is, a big barrier.
You have to navigate these self-pay scenarios now when you're talking to your patients. How fun is that?
It's a lot easier when we don't have to have those conversations.
Right.
The reality is, though, that not everything we do in medicine is covered. There's certain things that insurance companies deem cosmetic or unnecessary, and you see that list increasing. Even things that are standard like MRIs, are increasingly harder to get approved and paid for by the insurance companies. Mm. And so, navigating insurance is tricky. I can order an MRI for a patient today, and they can get it done. It's just whether or not their insurance company is going to pay for it is another barrier.
Which is the massive frustration that everyone deals with. And I think all the people who are patients understand how difficult it is, but it's also terribly trying for you and your staff here to manage that. So, I mean, why do you think it is that, and I think the big question is, why is it that this is not adopted? So if this was, if you were providing a medicine, like let's say a certain medication that had to go through like Big Pharma or something like that, do you think they would be delaying this long?
I
That might be a bit of a loaded question, but you know what I mean? Like there's no, like there's proof here. We know that it improves things. You have untold amount of people suffering from like arthritis that have Medicare and Medicare won't pay for it. That could benefit well from this.
Yeah, I mean, I think there's a lot of layers to this, right? So I think that anytime something is new, it's scrutinized. The reality is,
As it should be, especially in medicine.
yeah, the reality is 20 to 30% of the orthopedic surgeries that we do have level 1 evidence, which means that the majority of them don't have high level studies. The reverse is true for certain indications with PRP, like knee arthritis. But there are a lot of factors that go into this. I mean, there's no governing body that certifies somebody as a regenerative medicine specialist, right? So if the pocketbooks get opened, anybody in theory could potentially do these procedures, and there's a lot of science and a lot of nuance to there's doses that have to be considered. We're one of 2 clinics in Massachusetts that actually test the doses of platelets before we re-inject them. Majority of clinics don't go through that extra step of demonstrating what they're injecting. And so you see actors in the marketplace who may not be qualified to be doing these, and without a governing body saying this person's certified or not, it may be harder for the insurance companies to decide who they should pay.
Because there's been a couple of bad actors on the clinical side. So there were a couple practices I know in Florida, not even that long ago. I think there was one around like 2018 to 2020 where they were irresponsibly injecting like fat cells into women's eyes, and 3 women went blind from this. There was another one, I think, before that. I'm trying to remember the specifics of the case, but I think they were peddling off things that they said were stem cells, actually weren't, and charging people like $5,000, $10,000 for this. And both of them got shut down and everything like that. But, so this is kind of goes to what we were talking about earlier. There needs to be regulation, because we need to make sure there aren't bad actors, that people like me aren't going to have a clue what you're putting into my body if I need your help. So we need to know that if you're doing something irresponsible, you're going to be held accountable for that. So so do you think, because I look at it like this, we have payers often, as much as I get frustrated with a lot of the HMOs, a lot of them follow suit with Medicare, especially if Medicare has a place in the game. And I think Medicare very much does with this. Even though they're not going to deal with a lot of the student athletes that you deal with, there are folks who are seniors that certainly could benefit from this. And likely, if CMS adopts this, other payers are going to have to follow suit, as often is the case in this industry. But even like the American Medical Association, so they have a lot of the services as category 3, which kind of puts them almost like on the fence, where they're not, I feel like the AMA also should be a bit more active in this. Do you think the process of creating a regulatory body for this to make sure that there are accepted principles, standardized procedures, as frustrating as regulations are, is this what you think is the big thing holding the industry back?
I think that's part of it. We talked about, the first randomized control study for this came out about 15 years ago. And so there is 15 years worth of data, but the data is kind of mixed. A lot of it's missing dosing indications. And so the past 3 to 4 years, more and more studies have come out showing that there probably is a dose threshold to hit for these things to be effective.
Mm-hmm.
And so, some of these studies that didn't show benefit, maybe it was a dosing relationship. Maybe it was because it wasn't injected in the right place. So we do everything under ultrasound guidance to make sure that those cells are delivered to the area that's injured. And we confirm the area of injury with numbing shots beforehand. So, these have to be placed in the right place. They have to be placed at the right dose. And you have to use it has to be the right indication. A full tendon tear isn't going to do well with these things. Those are going to need surgery. And so there's a lot of candidacy issues that have to be figured out. And the literature has been kind of mixed in terms of how well that kind of lays the breadcrumbs for us to know what to do.
Right.
And so that's, another barrier, in terms of payers, so there's still a lot of work to be done. Now, the credentialing piece is separate. That's bigger medical organizations, the people who board certify you in physical medicine, rehab, or sports or orthopedics. these organizations haven't come out with a standardized test that people have to take to say that they know what they're doing in this realm. My specialty, PM&R, we were involved in developing a curriculum last year that was published on orthobiologics in terms of what these programs should be teaching their doctors as they're going through training about these procedures. And so as that starts to get implemented, you're going to see people who are coming out who have gone through the steps of being qualified. Right now, it's attending different lectures or conferences and reading. And, so a lot of this is self-learned. But you're going to see in the next 5 years that change where it's much more organized.
That's awesome to hear. And that's exactly where I was going to ask you next. Like, so do you feel like the dam is getting pressure and it will be breaking soon? Like, do you think that this overwhelming, I mean, the evidence is there, but getting to that next point where it can be standardized and managed and processed for the medical community and healthcare organizations to manage that should be coming soon, you think?
Yeah, I
Like,
think it's probably 5-10 years down the road, in terms of where we get. But people are working on this, and the American Medical Society for Sports Medicine, the American Academy of Orthopedic Surgery, both have statements that they put out, stating that their expectation is that the orthopedic providers, the sports medicine providers, are educated on this and they understand where these treatments fit in the broader algorithm. I mean, I don't think that's fully being implemented yet, but those organizations have recognized the need for educating their members about this, and so you will see more physicians, I think, know about this and figuring out where this fits into their treatment algorithm as we go forward.
Okay, so that makes me kind of think about the culture. So is there a culture of folks like you that are into this sect of ortho that get together at conferences or have different groups where you guys compile information, share information, ask each other questions when you have difficult cases? Is there some kind of, or even a society that you guys have where you guys are trying to advocate for yourselves, or maybe even have lobbyists in DC or something? What do you guys have going on?
They're not, none of them are big enough to have lobbyists yet, but but there's an Interventional Orthobiologic Foundation, which does a lot of training, and I'm involved with that. The Biologic Association, which is a member organization of a lot of other specialties that come together, and they do a meeting every year or two. The last one being in DC. There are other specialties. American Medical Society for Sports Medicine, which we mentioned before. They're in the process. We're in the process of compiling all the studies and putting together a document, kind of highlighting some recommendations around that. And so organizations are collecting data and presenting this at a higher level. They're smaller meetings, compared to these larger orthopedic meetings, but you're starting to see lectures even within the larger orthopedic meetings. There's people compiling data. So there's an organization called Data Biologics where we track all of our patients with surveys. So we have data not only about how our patients are doing, but we also have access to other doctors. I think there are 100 clinics in the country as part of this organization tracking their outcomes. So we can come back and we can say, all right, this seems to work really well. This isn't working as well. Is it a dosing issue? Is it a diagnosis issue?
Okay.
How do we get these patients better? So people are working on this stuff.
And where your work can be an alternative to surgery, does this create a natural battle between you, maybe and some ortho surgeons, or is this something that can complement practices? Like, do you like in the future, do you envision that there would be folks working in the same practice that are providing, because like you said, there are going to be some of your patients that need surgery. Like that's the best option for them. Do you think in the beginning, as you're pushing through here, there's going to be a lot of pushback from those folks, but eventually, like you said, 10 years from now, maybe things are going to be much more accepted and you guys are going to be funded appropriately by the payers? Maybe let's look 25 years from now, what an ortho practice looks like. Do you think it would be like a true blend?
Yeah, and you see that, throughout the country. There are orthopedic practices, and I've been a part of one. I've trained in an orthopedic practice where you have surgeons and non-operative musculoskeletal orthopedic doctors working together. I worked in a big group in Massachusetts where we had that relationship, and so I think that synergy is the best case scenario for most patients. We work closely with a number of different orthopedic groups. Having an independent practice, it's kind of freed us up to work with surgeons throughout the state, because I think that is the best situation, where you have somebody who's really good at diagnostic ultrasound, who can answer a question that maybe an MRI doesn't, can offer some of these needle-based treatments or precision-guided injections that you don't learn in orthopedic surgery. It's a different skill set. And so I think it gives the patients the broadest options, as far as management, when you have those collaborative environments.
So I know some of the folks that are, and I'm sure you're going to have a lot of your peers watching this, but I know there's some folks who are like practice managers at pediatric practices I talked to even just yesterday or the day before, that said that they want to attend and see what it is that you do. So what would you, if they, let's say for instance, they have some student athletes that are facing surgery and they have no idea if they want to chat with the pediatricians there about consideration for services like yours, what should be the process there? What should they research, or what kind of conditions specifically should they be looking for that may be candidates for this type of service as an alternative to surgery? Because I hate the idea too of, not that all surgeries have permanent markers that it leaves behind, but I just think of like children who go through, they like broken legs, or I mean that's a whole different story, but like going through some like actual major surgeries that could create ramifications down the line. And if there's alternatives to, especially because their body can't be much more healthy than it's going to be if they're like 16, 17, 18 years old for recovering naturally, I imagine they typically would be really good candidates for you.
Yeah. Generally, younger patients, under 45, our bodies behave differently. Once, you hit that 45 threshold, our biology changes a little bit. We see that in terms of how people respond to some of these treatments. Pediatrics, they're constantly turning over tissue, so they're, so in some cases, the body's going to take care of this without us having to kind of promote, additional healing. So age is a consideration, in terms of like how we look at every patient, just like their occupation, their sports and things along those lines. As far as the process of getting in to see us, a lot of times we'll talk to a patient about their diagnosis, what our treatment options are. We'll briefly discuss some of the surgical options for them. But a lot of times we'll have patients get a surgical opinion too. I think that, as a patient, you're trying to decide what your options are. We want all your cards on the table, so you can make an informed decision. And I think that, again, these collaborative environments where you can get those fairly easily are ideal. Not everybody has that set up. And, there's also politics with practices where, sometimes, you can't step on somebody's toes, so having an independent group, who, can look at things without having to worry about ruffling feathers, sometimes can be beneficial.
Interesting. Yeah.
And so,
that's good for them.
We do have a collaborative relationship with a lot of the surgeons in the area, but again, they're not everybody has that view.
Is there a case, and it doesn't even have to be with your work here, it could be any time in your career, that kind of sticks out as a great case to reference for why it is that you do what you do, or something where there was a great outcome from the services that you provide?
It's, the reality is that most orthopedic issues, most musculoskeletal issues, 85-90% of those don't require surgery. And so there are a lot of cases where we see people all the time, who have gone the surgery route and still have pain, or can't have surgery because they have a heart or a lung issue and they're not candidates for anesthesia. And these newer ultrasound-guided carpal tunnel releases, the average return to work for patients is less than a week, and sometimes even 3 days. And so, if you're unable to have a surgery because, you can't take 2 weeks or 3 weeks off of work, or, you're using a walker and you can't lose your hands because you'll end up in a nursing home for 2 weeks. So, there's so many different applications for this.
Yeah.
You know, if you're an in-season athlete, you know, can we get you through a season with shockwave, you know, versus, you know, having to
That's interesting. So it's all
miss your
conditional based
season.
on what the patient needs, and then there can even be like a temporary fix, like a Band-Aid thing. And then once the season's over, come back and then we can do this for you. That'll get you ready before next season.
Yeah. So, I mean, that's a fun thing is, you know, we see concussions to, you know, we manage you know, surgical fractures to, but really the tendon injuries and the arthritis, you know, giving somebody an option that isn't going to require a large period of downtime is really the most fun cases out there. But, you know, we'll see nerve injuries and just kind of the whole breadth. And so our day is kind of fun because it's not, you know, not the same thing over and over again. It constantly is challenging us to think outside the box and come up with a solution that fits that patient and where they are in their life at that time.
Interesting. Yeah, so I have a shoulder right now. I have a shoulder issue, right? Now, I've done my due diligence. So I've contacted ChatGPT, which is far superior to physicians, as you're aware. And I thought I might have a rotator cuff issue because I'm so skilled in diagnosing. And ChatGPT told me they think I have a partial tear in my bicep. Now, when I hear partial, I think that you guys would probably be a good place to go to ask for, like, you guys could run a, what would you do, an ultrasound or something like that to review and see what, and how long does it usually take? Like, I know we're in one of your exam rooms, right? I'm not going to have you examine me in front of everybody here. But I was going to say, like, if, let's say I was a patient, for you to determine, would you be able to determine pretty quickly if I have a rotator cuff issue, if it's a tear in the bicep, or by some freak of nature, both me and my ChatGPT are wrong?
Yeah. So, you know, combining your story, your exam, and, you know, the ultrasound will give us a lot of information. There's certain areas that you can't see well with an ultrasound inside the joint. And so there's a portion of the biceps tendon that does go into the joint. And so you can see tears that are, we may need an MRI, you know, in that situation. And, you know, so we could order that as well. But usually putting all those pieces together, you know, we can kind of figure out where the pain's coming from pretty quickly.
Yeah.
The benefit of the ultrasound is we don't need to go through the insurance process of getting prior authorization. You know, it's something we can do the same visit that you come in, and in some cases we can give you an answer, you know, with just the ultrasound. The MRI, you know, sometimes you have to jump through certain hoops. Like I said, you know, we could always order one. You can pay cash. You know, usually you can get that done within a couple of days.
Right.
But most insurances will require you to do physical therapy, which we can prescribe, and get an X-ray, which we can also obtain. And then order an MRI 6 weeks later. So it just kind of delays or defers care a little bit on the process.
Okay. Interesting. Great. So we should probably end earlier so I can get a quick examination in here. No. Let's see. So what else do we have? So that's interesting. I mean, that's a lot of the process of what you guys are going through right here. And I know you guys are growing. You guys have another clinician coming on soon. What are you looking to do with this practice, you know, long term? What are you looking to get into?
Yeah, I started this practice because I'm a patient too, and, you know, these bigger systems I think become harder and harder to navigate as a patient.
Mm-hmm.
When you call practice and you can't get in touch with the provider, you can't even get in touch with somebody in the practice, and so, you know, we're a small practice. The goal is to provide patients with access, you know, to care that's not going to frustrate them, to be able to offer the suite of options, you know, not have you go see, you know, one doctor for your wrist and another doctor for your knee and another doctor for your shoulder. So, you know, hopefully we can be kind of one-stop shop for a lot of musculoskeletal indications. And then if you need surgery or you need something that we don't offer, we don't do a lot of spine procedures. You know, we work with our colleagues for that. But otherwise, you know, to kind of offer, you know, one-stop shop for a lot of the primary care, sports medicine issues that are out there.
Okay.
Patients.
Well, you're probably going to kick yourself for mentioning that you're a patient, because that just sparked something in my head. So, yeah, you're a big hockey guy, right?
Yeah.
So, do you still play?
Yeah, just pick up. But,
right, but like,
leagues,
so you, I mean, God, how often do hockey? Like, so, what got you? Were you into this? Because I imagine hockey people are usually hockey people from a young age.
Yeah.
When did you start?
5.
Oh my God. So hold on. How many? Let's see the teeth. You got all your teeth still? Okay. But so how Wow. So did you get into this based on recovery needs that you've had? Did you have like a bad surgery at some point? Was this something that you like talk to me through the genesis of how you got to where you are now?
Yeah, I definitely had my injuries, growing up, but I've always liked anatomy. In medical school, I thought that was really interesting. All the imaging modalities so I initially thought I would go into radiology. I also worked for an ambulance company for a number of years before medical school. So I thought I was going to either go into radiology or emergency medicine, but I had a couple experiences when I was a medical student where I saw a sports medicine physician, starting to integrate ultrasound into their practice and combining the physical exam with ultrasound, being able to give people a diagnosis, on that day. It combined a lot of my interests in the anatomy and the imaging. And then, a lot of these newer cell-based treatments were just starting to be discussed, when I was in medical school. And I thought that was fascinating, that you could get somebody better with an injection in the same way you would with a larger surgery. And, those can really knock you out. And, again, going through injuries where you're sidelined for months, if you could speed that up by even a couple of weeks, that can make a big difference in your activity level and quality of life.
Okay. What's the biggest injury you've gotten?
I've torn some muscles. I've torn my ACL. I've had to have surgery for that, and so the recovery.
That's good. That must help you relate with your patients, though, right?
Yeah.
Like, because I mean, I'm looking at you and I'm thinking, because when I think hockey, I think you should probably look pretty beat up or something like that at this point. Because I look like I was big into boxing. My brother used to be a boxing writer. And a good boxer by the one whose face looks like Oscar De La Hoya was, a very handsome man, which means he doesn't get hit very much. So that's interesting. So you've had a lot of injuries, and that must help you connect with a lot of your patients.
Yeah, you go through a long recovery, and I'm glad I had ACL surgery. It allowed me to kind of return to skating and doing what I do. But the recovery is long. It's 6 months before you're back on the ice and 2 years before you kind of feel good. So
I would say 6 months if you're athletic, but
Yeah.
I mean, most folks aren't athletic, and it must be a much longer turnaround, right?
Yeah. So, and across the board, rotator cuff surgeries, can be a long recovery. And so, anytime you can help somebody avoid that, get back to things faster, that's the goal.
Okay.
With a lot of what we do.
Interesting. Great. Let's see. I think I've hit really just about everything I wanted to talk about here. Is there anything that I haven't hit? We've gone through all the services that you provide here.
Yeah, I think so.
And the comparison of really where we are in the industry. So, I mean, I guess if there's anything that not that I could do probably much to advocate for yourself. It sounds like things are like the ball's rolling. There's a lot of people who are really trying to do good things now. It seems like some of the bad actors hopefully were weeded out. And once this regulatory board or whatever it is, this commission is created to be able to allow this to become mainstream. I mean, I often look at things too, and I worry about the payer, because I always look at things usually in a cynical way, especially when it comes to insurance companies. I'm a rev cycle management guy, so the payers are often the major obstacle to get reasonable things accomplished. The second that CMS allows this, the amount of requests from folks who have arthritis to have these surgeries is just going to be countless folks that are going to be wanting these kind of services once they become mainstream, especially for folks that don't have to pay out of their pocket. So folks on Medicaid and Medicare, I mean, it's great that people can pay out of their pocket, but unfortunately, there's a lot of folks that I'm sure can't afford that. And so I always hate those kind of disparagements, as I'm sure everybody does. But also, again, for younger folks too, when you have these alternatives. But I would also think that, and with a lot of these things, if you come up with something better, it has a quicker recovery time, it's less invasive, and all this good stuff for the patient, typically that is going to lead to a stronger body and less issues down the road, or more resistance to issues down the road. And that payers should be embracing something like this, and they should be getting behind it, understand. I mean, how great would it be if, we've talked about how colleges want to bring your services in here, and they want to have the ability to reimburse for you guys. You said earlier, workers' comp manages a lot of this stuff. So anyone who's in the athletic field understands the value here. But people who are not there question it because it's not covered by payers. And so we want to get that gap, we want to bridge over that as quickly as possible. And I think that's really the main thing, because once that happens, then
I think the making sure you're going to somebody who's qualified to do this is really important, and practicing kind of an evidence-based way. There's some practices where you'll come in and they'll tell you need 3 PRP injections or you need 5 injections, when the data doesn't show that. It shows that, if you do 1, you're going to have an 85% chance of success. Why would you pay for 2 or 4 additional procedures when you only need 1? And, so you see that out in the marketplace as well. And so, you want to make sure that you're going to somebody who is trained in ultrasound or X-ray guidance, so that they can place the cells in the right place. Ideally, you're going to a place that can tell you exactly how many cells they're injecting. So for PRP, there's cell counters, and we can give you a dose. You never go to a pharmacy and just take something out of a bag without a dose on it, or knowing exactly what you're putting in your body. And then, somebody who has some background in this space, who's aware of the literature, who's offering something that has some evidence behind it, so that you're not getting an unregulated FDA amniotic product that's been banned in the US, essentially. And there's a great podcast called Bad Batch talking about this Livion scandal, where a lot of people got sick, on these drugs, which is one of these amniotic products, which is one of the reasons that they're banned in the US at this time. And so, I think trying to figure out, who, is your provider, qualified to do these procedures, just like if you're going to a surgeon, you'd want to make sure that they're qualified to do the procedure that you're requesting or that they've suggested, is important.
Yeah, it's terrible when the bad actors screw things up. I mean, we see that all across. You see it, and it's weird that both the examples I had from earlier, I think that's the one you were talking about too, right there. So often you see these scams happening in Florida, and then I don't know why. It's like Florida man also turns into healthcare, I guess. But it's what happens is it ruins it for all the potential good practice. It gives them reasons to pause. And it screwed it. I remember, in my office, I caught this person. They were on their cell phone during work time. So I was like, that's it. No more cell phones. That person ends up losing their job eventually. And now all the people who can't use their cell phones are people who are not using them anyway in the first place. And they're like, well, what if and so it seems so unreasonable and so unnecessarily punitive to beat up practices I shouldn't say beat up practices like it was, but to just have these restrictions and these hurdles that because of a few bad actors. I get it, but once we have appropriate regulations in, which I do think is very important to have in there, then hopefully we'll have a much better atmosphere. So
yeah, I think the medical societies they're looking at credentialing. That's, again, it's going to take some time. Again, my governing body, they just came out with a curriculum last year, so to develop the next step, which is standardization based on that, it's going to take some time, but that's coming down the road. And and just like not to pick on PAs, but PAs can't do a knee replacement. There's certain providers, you can't go to a chiropractor and have them replace your shoulder, so you want to make sure that you're going to a provider who has a background in this and has the skills and the level of training to be able to deliver this in a responsible way, especially since these are cash-based procedures. And I can't tell you how many times we have a patient who comes in looking for one of these procedures, and there's a less expensive covered option that's going to provide similar outcomes. And so, we talk a lot of patients out of getting a PRP injection or a stem cell injection when it's not the right thing for them, or there's another option that isn't going to be.
Yeah, I was a patient here, I think a couple of years ago for a knee issue, and Dr. Latska is who I saw, and he had these 3 different options, based on what you want to tolerate and we had a great discussion, and it's like a true conversation, which I really, really enjoyed. And your practice manager, before we got started here, Becky, had mentioned that maybe not necessarily Massachusetts, but in the country, there's a lot of ortho-based, urgent cares that are starting to pop up. Have they come to Massachusetts yet?
Yeah.
Awesome.
So you see them.
Or was it University? Do they have it? University?
I don't know if they do. There's one on Route 9, right down the road. So
awesome. Yeah. So I didn't know that these even existed, which is great too, because how often, I know when there's an issue with me or my kids, if I need to go to, and I don't want to go to the emergency department because I know typical issues like that, you're going to be considered low acuity. You're not going to be seen for 6 to 8 hours. You ruin your day or your night or whatever. And when you go to an urgent care, you don't necessarily know if they're going to have x-ray or what they're going to have in there for equipment. So that's great that that's a new thing that's popping up. So I hadn't heard of that before today. So so if any of you guys want, you guys should be aware that that also exists as well. Okay, great. Well, thank you very much for coming on the show, Walter. And we'll keep on pushing. We'll always back you guys so you guys can fight the good fight. Anything that fight the payers, I'm always on board. All right, now let's get to my examination. Thank you, guys. We'll see you at the next one. Next week, we have Tien, who is an RN turned CEO that is focused on the post-acute care world and doing great things for folks for home care and coming up with amazing models to really kind of like create a scaffolding to promote those kind of practices to get started and remain strong and not have big hiccups when things go wrong. We'll see you, I think, at her house because she's working out of her house right now. We will see you next week on that one, guys. Thank you very much. Oh, wait, hold on. We didn't do it right here. Boop, 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 boop. Super professional here.